All
Ah,
right, let's get this party started. Thank you guys so much for joining us today for our Zoom on dual diagnosis. I'm so excited. I like this topic because a lot of times when people are in recovery, um, people don't understand that always an underlying condition, and sometimes it is mental health. Um, and people just think it's just so easy just to, well, why are they doing drugs? Just stop. And sometimes there's another factor in play. And like I said, a lot of times, in many cases, it is people who are suffering from some kind of mental health condition. So that's going to be the topic today. Kenneth, you have the floor.
thank you. I'm just gonna share my screen with you guys. You have to. It says you have to allow me to be able to share my screen, Miss Glory.
Okay, no problem. Um,
Okay, so Carol's the last group.
Okay, so I do it on Zoom or that from?
I do, nope.
okay, I have to mute that real quick. Hold on one second. Most participants share simultaneously. Okay, you should be able to share your screen now.
Okay. All right.
Okay, perfect.
There you go. So, as Ms. Gloria said, today's topic is dual diagnosis, mental health, and substance use disorder. Um, Also, as she alluded to, how important it is for us to understand when we're providing treatment that there are also there's most of the time there's comorbidities that impact the way that we are able to provide particular services. Um, Sometimes it impacts the severity of the symptoms that we observe when we are providing treatment. So one of the things that we want to talk about today is being able to identify a person that is suffering from dual diagnosis and ways to be able to treat that person in the best manner as possible. We'll talk about a little bit about the overview about what we're going to be talking about today and what our objectives are. And that is for us to come up with and talk about the definitions, um, dual diagnosis, mental health disorders, and substance use disorders. Very important integrated treatment. Um, treating both disorders simultaneously as opposed to treating them separately. The other thing is understanding what integrated treatment is and the principles of it. And lastly, one thing that we want to that is a huge part of providing treatment on any level, and that's stigma. And I know that we all in a previous training we touched on stigma, and we're only going to talk about it a little bit this time. But it's only entered into this particular presentation just because of how important it is that we understand the mindset of the community as they are dealing with our clients and participants with dealing with not only one substance use disorder, but also a mental health disorder. So those will be our 5 objectives and learning points. And we'll start with looking at definitions. One of the things I'm going to ask is that you guys give me some help because I want to make sure that this thing flows pretty smoothly. So if you're called upon, if there's an opportunity to read, please read so that we can have some active discussion as we're going through the presentation. Our first screen is dual diagnosis definition. I'll start by reading the definition. Dual diagnosis is a term for when someone experiences a mental health. Sorry, my screen is blocked by you guys' face over there. A mental health and a substance abuse problem simultaneously. Dual diagnosis is a very broad category. It can range from someone developing mild depression because of binge drinking to someone's symptoms of bipolar disorder becoming more severe when that person abuses heroin during periods of mania. Either substance abuse or mental health can develop first. There is no pattern. There's no you don't there's no order of which you can develop one or the other. A person experiencing a mental health condition may turn to drugs and alcohol as a form of self-medication to improve the troubling mental health symptoms that they're experiencing. Research shows that the drugs and alcohol only make the symptoms of mental health conditions that much worse. Dual diagnosis. Can somebody please read? Mental health disorder. Could somebody please read the definition of this, please?
Okay, I can read this one. A mental health disorder, significant and chronic disturbances with feelings, thinking, functioning, and/or relationships that are not due to drug or alcohol use and are not the result of a medical illness. Bipolar disorder, major depressive disorder, schizophrenia, obsessive compulsive disorder, social phobia, borderline personality disorder, post-traumatic stress disorder, attention deficit disorder.
Thank you, Ms. Gloria. It's important to know that the definition makes sure that it emphasizes that the mental health disorder is not the result of some medical issue. It's not the result of some medical injury, but it is a chronic disorder that has to do with an illness that's dealing specifically with the brain and emotions. So we want to make sure that we make that distinction when we're looking at diagnosis and how we should be treating these people when we encounter them in our clinics and in our emergency rooms. Substance use disorder. Sanaya, can you read this?
A behavioral pattern of continual psychoactive substance use that can be diagnosed based on severity of symptoms. 4 C's, compulsion, control, cravings, consequences. Legal issue removed from DSM-5.
Yes. So the current diagnostic statistical manual doesn't have the legal issues that used to accompany the definitions when we would see substance use disorder. It's been, I suppose, liberalized in that regard. But most of the time when we see substance use disorder, those 4 C's are always accompanying the behavior that we're observing: compulsion, control, cravings, and consequences. Definitely consequences as it pertains to us seeing escalating behavior and aggression as it pertains to their interactions with other people. Symptoms of substance use disorders of those with mental health issues. Because many combinations of dual diagnosis can occur, symptoms vary widely. Mental health clinics are starting to use alcohol and drug screening tools to identify people at risk. Symptoms of substance use disorder may include withdrawal from family, sudden changes in behavior, engaging in risky behaviors, developing a high tolerance and withdrawal from symptoms, or feeling like you need a drug to be able to function. Some of the symptoms of a mental health condition can also vary. Their warning signs are extreme mood changes, confused thinking, or problems concentrating, also avoiding friends and social activities, and thoughts of suicide. There's a lot of different tools and ways that we assess the particular disorders that we're talking about here. I'm going to just add them to the chat. So if you have an opportunity, you can look them up and see if you guys use any. One of the ones that we use most often is the audit, and the audit is the alcohol use disorder identification test. It's 10 questions, and we usually use that when we doing a test inside of the emergency room, or if we're assisting legal authorities with a field sobriety test. Just catch the chat to see if I can put it in. Doesn't look like. Okay. The next slide.
If you can't put it in the chat, Kenneth, you can send me an email later, and I'll
Okay, I absolutely will.
Yeah, I'll distribute the email to everyone.
Okay.
Okay, thank you.
The next chart is actually just a comparison of how likely people with substance use disorder are more likely to be able to be using substance use. Someone who has a mental health issue or mental illness, the likelihood of them using particular substances. In this particular, in the first chart, we see a person with a personality disorder. He's 36 times more likely to become involved with alcohol. A person with a bipolar disorder is 23 times more likely to become involved with marijuana. Schizophrenia is the same with about 22%. Anxiety disorders, let me see if I can. Anxiety disorders are about 16 times more likely to become involved with alcohol, and depressive disorders and ADHD have a 16 to 18 time more, 10%, 10 to 16% percentage more likelihood to be involved with opioids. On the flip side, it shows that people who already have substance use disorder, that their likelihood of using substances, with the key on the side, it tells you, I don't want to have to go through all of them, but it shows you the likelihood of them using the substances and what they're using. With alcohol being in the blue dot, marijuana in the green, opioids in the red, the orange, and cocaine in the red. This particular graph talks a little bit about talks about the likelihood of it and how the two actually are the comorbidities exist quite prevalently in regards to most of the time when we see somebody, the dual diagnosis attachment or moniker is usually in place, especially when we are encountering them in emergency rooms and in some of our field operations. Treatment. The best treatment for dual diagnosis is integrated intervention. When a person receives care for both their diagnosed mental illness and substance use disorder, the idea is that you cannot treat your depression because you're also drinking. That kind of thinking is outdated. The current thinking is that it requires both issues to be addressed simultaneously. You and your treatment provider should understand the ways each condition affects the other and how your treatment can be most effective. Treatment planning will not be the same for everyone. Cannot take the cookie cutter approach when trying to create an individualized treatment plan. It has to be set up in a way that both issues are being addressed at the same time, so that when there is any kind of setback or anything like that, that both situations are going to be addressed accordingly. And here's an example of integrated treatment. Somebody please read this.
Integrated treatment for co-occurring disorders differ from traditional approaches in several ways. First, services are organized in an integrated fashion. For example, assessment screen for both mental illness and substance use. Consumers receive one consistent integrated message about substance use and mental health treatment. Second, clinical treatment is integrated. Integrated treatment specialists have knowledge of both substance use disorders and serious mental illnesses, and understand the complexities of interactions between disorders. They are trained in skills that have been found to be effective in treating consumers with co-occurring disorders.
Thank you. The practice principles. Mental health and substance use treatment are integrated to meet the needs of people with co-occurring disorders. Integrated treatment specialists are trained to treat both substance use disorders and serious mental illness. Co-occurring disorders are treated in a stage-wise fashion with different services provided at different stages. Motivational interventions are used to treat consumers in all stages, but especially in the persuasive stage. Substance abuse counseling uses a cognitive behavioral approach and is used to treat consumers in the active treatment and relapse prevention stages. Multiple formats for services are available, including group, individual, self-help, and family. Medical services are integrated and coordinated with psychosocial services. I'm sure some of you all have seen this particular slide before because we had it in our previous training in regards to stigma. One of the major obstacles that we as care providers are run into lots of times is based on how the community perceives not only our clients, but the way that we go about the methods that we go about using to engage our clients. So in large part, when we're in neighborhoods and we're trying to do, for example, a needle exchange or a safe place for our clients to come to, we run into a bunch of people, or sometimes we run into neighborhood groups, unfortunately, sometimes faith-based groups that do not want us there. And a lot of their apprehension is based on the stigma that comes along with not only the people who are suffering from substance use disorder, but also to the providers of those with those services. So stigma is defined as a mark of disgrace or infamy, a stand of reproach, or as one's reputation. Stigma remains the biggest barrier to substance use treatment faced by clients. Mental health stigma refers to societal disapproval or when society places shame on people who live with a mental illness or seek help for emotional distress, such as anxiety, depression, bipolar disorder, or PTSD. So in the past, we've talked a little bit about the different kinds of stigma. There's actually seven types, broke down into 3 different categories. The category that we'll talk a little bit about today, but we'll get a chance to touch on all of them. But the category that we're that we want to focus our attention on are the public stigma and the health practitioner stigma as well. Type 1, public stigma. This happens when the public endorses negative stereotypes and prejudices, resulting in discrimination against people with mental health issues and conditions. Has anybody, any of you guys that are working in the community, have you ever encountered or engaged anyone who presents these kinds of stigmas or talk in this manner when you're trying to provide services?
Yes, this is Richard. I work at a treatment center, and I'm outreach for that treatment center. And I have to, at different times, transport them, and having just a common conversation with them seems to be extraordinary, for a better lack of words, if that answers your question.
Yeah. Thank you, Richard. I was just exposed to a new acronym in working with. We've been lately doing some outreach on the South Side, where we're working in conjunction with a food pantry, and a lady told me that their community suffers from something called NIMBY, NIMBY. I had never heard it before, and it stands for not in my backyard.
All right. I heard the same thing just recently.
Yeah.
I just heard the same thing recently. Yeah.
I was blown away. I was like, it's catchy, but it's extremely negative.
Yes.
Yeah. So I was kind of taken aback by that, but at the same time, I understand, because of the preconceived notion that you're going to be inviting a particular element into your neighborhood or your backyard, if you will, in regards to providing services, and for us over there trying to provide services. As we see the circumstances around us seem to be becoming more and more deteriorated. More and more people are looking for services from a community-based level. More and more people are looking for things like food pantries and places where they can get services on the street. People who are, we're having we're not just handing out Narcan now. We're collaborating with other people to provide vaccinations and all kinds of health information and things of that nature. So as things start to escalate and as the winter is coming to set in, we're looking at us coming into contact with more and more people who have dual diagnoses, people who are suffering from a lot of anxiety and undiagnosed bipolar disorders, along with their substance use disorders. So it's very, very imperative. And I thank Ms. Gloria for touching on this topic, just because that's something that we're seeing more and more of. And as the winter months approach, we'll probably be seeing more and more of those as those people become displaced and are looking for community-based services out in the areas where we're going to be working.
One of the things, I'm sorry, one of the
Go
things
ahead.
that I have discovered or viewed, this kind of diagnosis is, believe it or not, is seasonal. We tend to have more of, let's say, as you mentioned, the winter months due to the summer months, because they can reside anywhere during the summer months. So they'll go the whole summer months undiagnosed until the weather begins to change, and then they seeking these services. And it's been my experience that a lot of them is not rebellious against the services, but don't understand the services.
That's a fantastic point, because I that's an observation that I have been making as well in regards to just more people just presenting with more problems and with more issues that go far beyond me being able to direct them to treatment for substance use disorder treatment or a simple checkup. The broadness of the services extend beyond what we're there to do. So that's one of the reasons why we have been partnering with other teams that provide more or less kind of like full service, that can do an evaluation and they can do intakes and assessments right there, maybe do some type of mental health triage, if you will. So thank you, Richard. That's a great observation, and it's one that I have made already on my own in regards to some of the things that I've observed out in the community. So for the sake of time, we'll keep going. Can somebody read type 2 of stigma?
Type 2 self-stigma.
Yes.
Self-stigma happens when a person self-stigma happens with a person with a, it must be a with a person.
It's a misprint, Ms. Gloria.
Right.
It's not you.
Okay, I was just making sure. With mental illness or substance use disorder, internalizes public stigma.
Okay. So usually that's a person who understands that they have this disorder, but it allows them to maybe to internalize this, and it impacts them in a way to make them have poor body image, poor self-esteem. It affects the way that they interact with people, and it's also going to affect them being motivated enough to be able to come out and seek treatment. In most cases, when we encounter people who have self-stigma, they're kind of caught up in the idea that this is who they are and who they're going to be forever. So it's that's why it's important for us to be able to be empathic when we're engaging people in the community, especially if we see signs of self-stigma like this, where we hear a lot of kind of self-degrading, self-deprecating kind of language, that we are very, very patient and empathic when we're dealing with them, and make sure that we have referral information and things like that on hand, and as a means of being able to refer them to additional services, along with whatever it is that we can provide to them on right there on site. Type 3 is similar in this regard, because a lot of times what we internalize feeds into what we perceive. So perceived stigma is the belief that others have negative beliefs about people with mental illness. So a lot of times when we see people that have stigma, that have internalized self-stigma, a lot of times what they think is that their outside perception, their outside the way that we observing them is the way that they see themselves. The way that manifests itself in most instances is that they're very defensive, argumentative, and difficult to approach in that regard. Again, we have to employ the utmost empathy in regards to working with that particular client population, and with people that are suffering from this, and be very, very observant of that kind of language and things like that, and patience. Not to the point that we're putting ourselves in any kind of safety issues where we're compromising the safety of our teammates or anything like that, but making sure that we are exhibiting the utmost patience and empathy when we're dealing with them, because for the most part, it's the illness, it's the disorder that is at this point governing the behavior and the appearance of the person. And it's our job to see, to the extent that we can provide services and help. Number 4 is the label avoidance. And this is when a person chooses not to seek health treatment to avoid being assigned a stigmatizing label. Label avoidance is one of the most harmful forms of stigma. I don't know about you guys, but I probably experienced this the most, just because when I'm talking to people and I'm talking to them about dispersing Narcan, and I'm telling them that this is the overdose reversal drug, their first knee-jerk response to me is that I don't have any use for that stuff. I don't use it. And in some instances, we've had lines of people who have been exhibiting overdose symptoms right there within our line. What we try and do is to talk to them about our mission is to saturate the community with Narcan, and whether or not you are disclosing that you are someone who suffers from substance use disorder. If you know someone who suffers from substance use disorder, please take this kit and pass it along to them, because what we want to do is normalize having Narcan in every home, in every car, with every person, just like we would with someone who uses an asthma pump or carries an EpiPen and things of that nature. But a lot of times what they're doing, and it's not just with people who are suffering from substance use disorder, it's people every day who don't want to be associated, just by way of stigma, don't want to be associated with people who are using drugs. Has anybody else had any similar experience in that regard with label avoidance?
Yeah, Richard again. I have just recently, I had to go to a parent's son's place of residence, and I was trying to offer him the Narcan and everything, and he avoided that at all costs. And he was like, well, that would put he even said it, that would put a label on him, he's an addict. But the guy, the ambulance, the police, and everything was there. So I think that he was more worried about how it would look, opposed to saving his son's life or having this kid at all times.
Exactly. We encountered similar situations like that all the time. Anyone else have any experience like that? I'm gonna pick on my intern a little bit. Sanaya, have you had any experiences like that you've been going out with us?
All right, can you repeat the full question?
The question was about type 5, stigma by association.
Yeah, I think more often, like when we give out the Narcan, people don't, even if they're not using, they don't want to take it because they don't want to seem like they're using, or like if I say like, oh, you can give it to somebody that you know, like, oh, I don't hang around those kind of people. And like there was even one time where they said that to us, and then we walked away and they ended up walking back past them. And then they told us about this guy that's by their house that they know uses. And I was like, well, why don't you take one to give to them? And then they was like, I don't know. I just don't want to really interact with them. But they ended up taking one anyway.
Yeah. Now we do encounter a lot of that. I'll say it's as soon as yesterday. I was out yesterday we were out at an event yesterday, and I talked to a young lady, and she was her apprehension was about administering the Narcan if she saw someone suffering from an overdose, and what would happen afterwards, and would the police want to question her and everything like that. So I explained to her about the Good Samaritan Act or whatever. But one of the things, and it's probably not on here, one of our biggest battles with what we're up against in regards to disseminating information, providing treatment, is television and social media, and how things are dramatically depicted on TV. We're handing out nasal Narcan. The young lady was under the impression that I was handing her some syringe-like device that she would have to stick into somebody's leg. And after I provided her with the demonstration, she was still not convinced that it wasn't. She told me that she had just recently saw an episode of Chicago PD where they had to administer Narcan into the leg of somebody, and I was like, I'm sure that's a pretty outdated version of the Narcan. Because even the firemen and the emergency teams that we work with are all using the nasal form of it. But she actually walked away and then came back and got a kit from me, which was it made me feel better. But it also just gave me a broader sense of what it is that we're up against when we're talking about trying to administer this kind of information, and what kind of information has been given to just the general public. Lastly, I want to talk about the health practitioner stigma. And this stigma takes place anytime a health professional allows stereotypes and prejudices about mental health to negatively affect the patient's care. I mean, I've had experiences working with that. I mean, I work in a pretty big hospital, so some of my experiences I probably run the gamut of all these experiences. But I'd like to give you guys an opportunity to talk about it if you've had any of those experiences at all, and then I'll share any experiences with any kind of healthcare professionals that have where stigma has somehow come about during your conversation, or somehow impacted the way that you were able to provide services. Anybody? Okay, I'll go. No problem. So I work for Rush. So one of my many duties is that I actually teach a class of residents The residents are already doctors. They do rounds. They're the younger doctors. They're about to be the doctors who will be providing. They'll be moving up to the next level. I don't know if that is being primary care physicians or whatever, but right now they're basically learning by doing rounds. And once you're moved up on, if you're sick, you get moved up to a floor. That doctor is monitoring that particular area of the floor. So one of the things that our particular division of behavioral health is that we provide them with cultural competency. We teach them about race and psychiatry and working with diverse communities. And in a lot of the scenarios, and I'll just give you guys one for the sake of time. I know we got a hard stop at 11, Miss Gloria. I'm keeping that in mind. One of the and I won't make it long. It's one of the we give case studies to each one of them to kind of talk about what their experience is and to put them in a learning experience to see what their reaction is. One of our case scenarios is where a young man has a mental health issue, and his mother has to bring him to his appointment on the public transportation service that we have, the L. She calls ahead to let the office know that she's going to be 20 minutes late, but that her son needs to see a doctor just because he's been having a lot of trouble in school. He's been exhibiting a lot of erratic behavior. They're not going to let him back in unless he sees a doctor. She gets there, she's 20 minutes late. The attendant is kind of rude to her in regards to not looking at any ways that she could maybe help or mitigate what the situation is. The lady is pleading with her. She says that she's called ahead. The attendant, the secretary, is very, very stern, very, very matter of fact, lets her know that she'll have to reschedule for another month. So that means that the next appointment would be a month away. The total time for the evaluation is about 90 minutes. She's 20 minutes late. She asks if she could be put to the end of the line. She doesn't mind waiting. There is no recourse, according to the secretary. The secretary at this point, there's voices being raised. There's a near altercation. Ultimately, secretary calls security, in which case security becomes involved, and now it looks like the mom may be arrested in front of the young man. Now, well, I ask you guys, are there any other ways that this situation could be rectified or handled? Do you guys see any ways for that situation to be handled differently?
And just to confirm, the son suffered from some kind of mental health disorder?
Yes, he's been brought to see a psychologist or clinician. Well, we don't know to what degree, if he's a psychologist or psychiatrist, but he's a clinician.
And the mom, she called ahead to let them know that she was going to be late.
Yes.
Yeah. Yeah, I just think that people need to have more grace, especially when you see when you're dealing with things like mental health. Those hard and fast rules like that, I don't see how they benefit the patient at all. You know.
And that's exactly what I think is missing.
Mm-hmm.
That level of grace is missing.
Yeah.
I'm always amazed at how strict and strenuous rules and regulations are as it pertains to people in the health field.
Mm-hmm.
Okay, so for me, one of the examples that I give to students is, well, first of all, the assumption is that because she's 20 minutes, she's going to be 20 minutes late, she's on the train, that the first assumption is that she's a person of color. That's the first assumption by most of the students. The other thing that I find to be kind of extremely rigid is that you also have a 90-minute slot that you've allotted for this person. And that person is 20 minutes late.
Mm-hmm.
Why not allow that person to get those 70 minutes? Because if I can give them that young person 70 minutes, that's a lot better than giving him 0 minutes and making him wait another month.
Mm-hmm.
The other thing that I don't like is that this scenario takes place in an open space. So confidentiality is thrown out the window.
Yeah.
And then there's also the aspect of when you're having this conversation in the open space, that voices are going to be raised. Just the whole idea of adding an audience to this equation goes a long way toward escalating it. So I just think that a lot of it, I'm not absolving the mom for anything. If she did anything, or if any behavior has been observed in a way that was detrimental to her son being able to have this appointment, then I think that she does have to accept some responsibility in it. But I think the majority of the responsibility has to fall on the health practitioner and his office. Because ultimately, if he or she is there to help somebody, then they definitely have to be looking in terms of having flexibility to be able to do that.
Mm-hmm.
And unfortunately, in our day and age, we don't see a lot of flexibility. We see a lot of, for lack of a better term, better luck next time kind of approaches. And in my opinion, I think that a lot of that comes from stigma.
Yeah.
A lot of the stigma presentations that we go through, and the scenarios that we go through would be as useful, if not better used with a lot of the administrators and doctors and leadership, because I think those are the things that are lost now in regards to doing treatment. Well, especially with people of color, especially with people that are income challenged in a lot of ways, and especially for people who are dealing with not just one level of substance use disorder, but also being dually diagnosed and having a mental health issue as well.
Mm-hmm.
Okay. So I am off of my pedestal right now. I appreciate you guys humoring me for a minute. There might be one more slide here. Okay. So we've talked a little bit about the effects of stigma. How the internalization of negative beliefs goes a long way toward how we engage, how our clients that suffer from substance use disorder, how they engage people in the community, and how they are engaged. It leads to social isolation. It severely limits the resources and services available to them. Low self-esteem, hopelessness, shame. That's the self-stigma that we're talking about. But I think it's all interrelated in that regard, because I think stigma on any level has a negative effect on us. But some of the bigger issues are that it leads our clients to avoid treatment. And when you avoid treatment, it only worsens our symptoms. We have a lack of representation in the criminal justice system. And even those of us and those of our clients who are able to work, because of that untreated substance use disorder or that untreated mental health issue, there's discrimination of us at work, where our work environment is made almost impossible to be able to exist in, and ultimately it ends up making us unemployed. So all of those things are being so interrelated, leads us to understand that there is an aura of sympathy that we have empathy, that we have to employ when we're working with people that have dual diagnosis. Not only to the degree that we see them and are able to engage them when we are out doing outreach or whatever, but making sure that there's an opportunity and a process to be able to follow up, for them to be able to get continued services, and for a way for us to continue to be able to get that message out to those people. So this is actually the first part of the presentation as it pertains to dually diagnosis. There's another part that talks more about the diagnostic piece and assessment pieces that we can get to later, according to what Miss Gloria's schedule permits. But this is part one of our dually diagnosis presentation. So if you guys have any questions, we still have a few minutes. Questions, comments?
I think we should definitely do part 2 in November.
Okay. All right. Anybody else? Sanaya, you on here? You still with me?
She says yes in the chat room.
Let me see if I'm able to. See if I can. Yeah, I was able to finally post. Well, I think I sent it to Miss Gloria. Let me see. What I was able to finally post some of the actual audit. I mean, some of the assessments that are used. The audit is one for alcohol. The DAST is one for 10. DAST 10 is one for drugs, and the CRAFT one is actually for kids. So it's the one that they use for teenagers. Try to see if I can remember. It's C stands for car. R is for car is for C stands for car. A stands for alone. I can't remember. It's been so long since I did that. Well, you just have to do it with high schoolers. But they're very, very good assessments to let you know whether or not a person needs to get further treatment for alcohol and drugs. In the next portion of the presentation, we can talk more in depth about assessments and how we use them to further treatment. And yeah, I think it'll be this presentation will be a good segue into continuing that discussion.
Yeah, I think so too.
Yeah. All right. So if there are no more questions, I can stop sharing my screen. Thank you as always, Ms. Gloria, for having us.
Yes, thank you. We appreciate it. We appreciate your time. We appreciate Rush. So thank you so much.